are a few other skin disorders that we want to highlight and give you some of the points you need to know, both to care for these patients, but also for exams and the NCLEX. First, we want to point out a couple things you might see on your patient's skin. The first is petechiae. Now, we've talked about this a little bit when we talked about DIC and thrombocytopenia. They are small red spots that don't change color. And they're very common in bleeding disorders. Essentially, it's a tiny spot of bleeding up under the skin. So if you see petechiae, you think bleeding. Then the second is a keloid. Keloid is an irregular, thick, dark area of scar tissue, like what you see here. So this patient had a simple appendectomy and developed this large keloid scar. This is very common in African Americans and darker skinned patients because of their high levels of melanin. Contact dermatitis. We can essentially break down this word and figure out what it means, right? We know it's inflammation, and derma means skin, and contact. So it's inflammation of the skin because of contact with something, right? So typically it's due to an allergic reaction of some sort. In this case, this child had an allergic reaction to poison ivy that touched her skin, and it caused this contact dermatitis. So it could be vesicles or blisters, redness. You could also see hives. The vesicles could be oozing. You could have scaling, especially as they start to heal. So it looks a little different for every patient, but we know that it's an allergic reaction. They've contacted something and it's caused this inflammation in the skin. So first things first is we want to make sure that we remove the exposure to whatever the allergen is. So we need to maybe clean off their skin or take off a piece of clothing that might still have, for example, poison ivy on it. And we want to identify what that allergen was so that the patient knows what they're allergic to. So as far as treatment, we're going to give corticosteroids. We can give topical things like a hydrocortisone cream. And we can give topical antibacterial agents or astringents. We could also give a topical antihistamine. Again, we're trying to stop that allergic reaction. So antihistamines are the good way to go. So that's contact dermatitis. Again, make sure you identify the allergen so the patient knows to avoid it in the future. Next is frostbite. I'm sure you've heard of frostbite, at least from TV or movies, and you see these guys climbing Mount Everest and their noses and toes are black and they're falling off, right? Well, in the late stages of frostbite, that is a very real possibility. Frostbite happens because of excessive exposure to cold. When you're cold, your body vasoconstricts all of those tiny blood vessels in your non-vital organs to try to keep the warm blood flowing to your vital organs. This means that your arms and your legs and your face and the rest of your skin tend to get the shaft. But before they turn black and fall off, they're going to be this silvery white color, and they might even blister or crack. Again, this is like the smallest areas of your body first and the ones farthest away from your heart. So we see it on fingers and toes. We see it on the tips of the nose, the tips of the ears. So our goal for care for these patients is going to be to re-warm the area as quickly as possible. We can use warm water. We can use towels. We can use a warming blanket. Whatever it is, we need to get the area warmed as quickly as possible. And that's actually going to help provide some vasodilation and improve circulation to the area as well. Ultimately, our goal here is to salvage as much tissue as possible. Keynote here, I've seen people put a hand, for example, in a bucket of warm water and then just leave it, and 45 minutes later, they come back and that water is ice cold. You have to change the water. So remember, continually cycle out a fresh bucket of water every 10 or 15 minutes or so to make sure it's warm. We rewarm the area and salvage as much tissue as possible. Next is MRSA or MRSA or methicillin-resistant Staphylococcus aureus. If you've been in nursing school for 5 minutes, I'm sure you've heard of this. It is a drug-resistant superbug that patients can contract in the hospital and sometimes out. If it gets into a wound, it can absolutely wreak havoc. Now, not only is it damaging to the tissues, but it's just very hard to treat because it's resistant to antibiotics. It's also highly contagious and it spreads by contact. So we're going to put patients in contact isolation. We wipe down all the surfaces really well. Make sure that you're not even taking your own equipment. Don't take your own stethoscope into that room. Don't use your own pen. Don't use your own scissors. Most facilities will have specific isolation stethoscopes you can use. They'll have a pen they put in the room that stays in the room. Again, disposable equipment that can go in that room, stay in the room for that patient so that you're not touching your own things, you're not touching your own stethoscope. Now, if for whatever reason you absolutely have to, make sure you're cleaning it thoroughly with whatever the wipes are at your facility. So my facility, they're called Cavi wipes. So make sure you're cleaning them really well before you come out of the room. Now, as far as wound care, we want to be really, really strict with these wounds and maintain sterile wound care technique, because if, let's say that he had a tiny little wound over here that wasn't MRSA, it was just a little skin tear, and I'm really sloppy with my wound care, and this MRSA now gets into that wound, right? So it's so contagious, it spreads so easily. So it's extremely important that you're taking the right precautions to keep it from spreading. Now, lastly, I want to talk about Stevens-Johnson syndrome. If you've been through pharmacology in nursing school, or if you've done our pharmacology course, you've probably heard of this syndrome. It is a drug-induced skin reaction. Essentially, it is a horrible, life-threatening adverse reaction to a drug. Now, when I was in pharmacology class over 10 years ago, I remember them saying, oh, it's very rare. It's very rare. You're probably not going to see this. But I actually saw it half a dozen times in my first 2 years as a nurse. So keep that in mind. It is the most common drug that causes it is sulfamethoxazole trimethoprim, which is Bactrim. And we give Bactrim for UTIs. So a lot of times you'll see that common link there where they just started Bactrim or they've been on Bactrim for 6 days and suddenly their skin starts to slough off. So essentially, again, it's skin sloughing. So Stevens-Johnson syndrome is when the epidermis begins to separate from the dermis and then it just falls off because there's nothing holding it on. So of course, when that happens, it causes inflammation and even some bleeding. The key thing to note here is that it begins suddenly and it progresses rapidly. So if you're in a clinic or an emergency room and someone comes in and they say they have this rash, it just showed up on their chest yesterday and today it spread to their neck and their shoulders, you need to suspect Stevens-Johnson syndrome. It spreads really quickly and it can begin to affect the face and the inside of the mouth and these mucous membranes. And of course, if we get swelling and inflammation inside the mouth, we have a really severe risk for airway compromise, okay? So we want to identify the cause. If it's a drug we're giving, we want to stop giving it. And then we're going to care for these wounds. Now, in most cases, because of the massive loss of epidermis, we're actually going to treat these patients like burn patients. So we're going to give them antibiotics and steroids. We're going to do strict dressing changes, strict wound care, and really, again, they've lost their protection and their barrier from infection. They've lost their barrier against losing fluids. They've lost their temperature regulation. So we're going to treat these kind of like a burn. We want to make sure we decrease the swelling with those corticosteroids, stop that immune response to the drug, and monitor their airway and their volume status just like we would with a burn. Now, our top concept for a patient with any of these skin conditions, of course, is tissue skin integrity. Now, what we want you to see here is that there are so many things that can cause a patient to have poor skin integrity or to be at risk for it. Remember, the skin's a barrier against infection, helps regulate temperature, helps hold fluids in. So anytime there is a skin integrity issue, we're considering those things, especially infection. We want to keep wounds clean and do proper wound care, no matter what the type of wound is. We want to prevent further breakdown of skin from whatever the source is. So that's the purpose of these nursing concepts, guys, is to help you see patterns, see big pictures for these patients. So anytime you see a skin condition, no matter what it is, you think tissue skin integrity and you can implement the right interventions for your patient. So when it comes to skin, we want you to remember to assess their skin a lot. We do detailed skin assessments on admission with 2 nurses every shift change and with every head to toe assessment. You should be assessing skin under their gown, take off their socks, lift up the blanket, look on their back. If you don't, you are going to miss something. Then remember, we always want to treat or remove the cause like a drug or an allergen, and we want to do proper skin care and wound care and isolate the patient if needed. Okay, guys, I know I said this in pressure ulcers, but we want you guys to be skin champions. We want you assessing skin like nobody's business and taking such great care of your patient's skin. The NRS&G family is going to be amazing skin protecting nurses. All right, guys, go out and be your best selves today. And as always, happy nursing.